Hello, my name is Patrick Ryan. I am Vice President of Observational Health Data Analytics at Janssen Research and Development and Professor of Biomedical Informatics at Columbia University. Before I begin, I'd like to first thank the Korean Health Review and Assessment Service for putting on the HERA Big Data Forum, and to thank Dr. Rao for the invitation to participate. I'd also like to thank Dr. Sen Chan Yu and Dr. Rae Woon Park for their ongoing collaboration. I'm here presenting on behalf of the Odyssey community, and my presentation is entitled Using Healthcare Big Data in Pandemic Response by Characterizing Disease Natural History and Predicting Patient Outcomes. You heard from my colleague, Dr. Danny Prieto Alhambra, about the Odyssey community and its use in supporting the pandemic response through various analyses evaluating the safety and effectiveness of medicines. And today I'd like to carry on that presentation to talk about other opportunities for using observational data to study disease and generate reliable real-world evidence. So as we've highlighted, the Odyssey community is trying to bring together observational data from around the world to be able to support the pandemic response. Collectively, across the Odyssey community, we have brought together 18 different data sources covering over 4.5 million patients tested for SARS-CoV-2 and over 1 million patients who've been diagnosed or tested positive for COVID-19. These data sets reflect administrative claims data, electronic health record data, hospital data, as well as other information linked together. What's important is that we've recognized that there is no one database anywhere around the world that can give us the answers to the global questions that we're facing, but there's tremendous value in being able to learn across multiple databases. This is why we are particularly appreciative of HERA for their leadership in Korea in supporting the Odyssey community for us to be able to learn as the pandemic started in the Asia Pacific region and to learn as it is borne out across Europe and the United States. Now, as Danny highlighted before, the Odyssey community relies on the use of a common data model and standardized analytics to support its work. So that means each individual data source around the world is first converted to the OMOP common data model. And by having data in a standardized format, it means that standardized analytics can be sent to these sites. Those sites can opt to participate in research, generate aggregate summary statistics, which can be compiled together as an open evidence source to generate information. And you heard earlier about examples of this being done to study the safety of medical products. And what I'd like to highlight for you are some of the other complementary use cases that we use these observational data for. Before I do that, I want to reinforce the notion of how do we generate real-world evidence to ensure reliability. Part of that process is making sure that the entire process of generating evidence is fully transparent. That includes the process of standardizing the data, evaluating its data quality, issuing protocols that fully specify the analyses to be performed, developing standardized analysis packages, evaluating study diagnostics to ensure the results are credible, and ultimately producing results that can be made available through interactive websites. By following all of these steps, we ensure transparency. But transparency is really an objective that supports us in being able to increase the reproducibility of scientific research, to improve its interpretability, and ultimately to ensure that we have trustworthy results that can be used for decision making. Now, we talk about different use cases that can be supported using observational data. You heard earlier about population level effect estimation, the question of causal inference. Right now in this presentation, I'm going to focus on clinical characterization, the basic questions of what happened to them, descriptive summary statistics about observations that can be observed in real-world populations. And then I'll also highlight the work the Odyssey community has done for patient-level prediction, taking those observations of what's happened to them to answer the inference question of what will happen to me. In the characterization space, the Odyssey community has been active in thinking about how we can use real-world data from around the world to better understand the disease natural history of COVID-19. One of our first efforts was to describe the baseline characteristics of those patients hospitalized for COVID-19, comparing those to those who have previously been hospitalized for influenza. Early in the pandemic, there were questions about the severity of this disease and how it may manifest differently in those who've been hospitalized with the flu. And the key findings of our work were that patients who were hospitalized with COVID were systematically different, including having a greater proportion of patients who were male, slightly younger, with fewer comorbidities and lower medication use, suggesting that COVID was inflicting patients who were otherwise healthier than what we see for those typically hospitalized with influenza. To perform this analysis, we were able to utilize administrative claims and electronic health record data from 10 different databases in 3 different countries. And we were very excited to see Korea's leadership with the HERA dataset contributing. This paper, which is currently posted on medRxiv, has been accepted for publication in Nature Communications. You can see the long list of authors here, including Dr. Sen-Chan Yu as the second author of this important manuscript. What I'd like to highlight in this work is that by looking across multiple different databases, we can gain a tremendous perspective on this disease. And by thinking about systematically summarizing not just one particular hypothesis, but all of the baseline medical conditions and all of the medication uses across these patients, we can start to put a fingerprint on this disease. You can see in this table that we're summarizing multiple different databases from the United States, Korea, and Spain. And what you're seeing in this colorful plot is the relative prevalence of each and every possible condition and each and every possible drug across all of these databases. And by being able to examine these patterns, we can start to understand this disease at a much broader scale than what can be learned simply by the individual case reports that were issued earlier on in the disease process. Building on this work, the Odyssey community has started a large project called Characterizing, Characterizing Health-Associated Risks in Your Baseline Disease in SARS-CoV-2. Our objective was to be able to describe the baseline demographics, clinical characteristics, treatments, and outcomes among those tested for SARS-CoV-2 and or diagnosed with COVID-19, both overall and stratified by important subpopulations. We described the characteristics and the outcomes of patients who were diagnosed or tested positive for influenza as a comparator group as well. As with all of the Odyssey studies, we tried to follow scientific best practices, which included issuing a protocol, making the full analysis code publicly available, inspecting study diagnostics, and making all of the results publicly available on an interactive website. To highlight how we've thought about understanding disease natural history of COVID, I'll describe the target populations that we studied. We start with patients tested for SARS-CoV-2. Within there is a subset of patients who are tested positive. There's a broader population of patients who are either tested positive or are diagnosed with COVID-19. Within that subset, there are some patients who are hospitalized with a positive test, and a broader group that are hospitalized with a diagnosis or positive test. And amongst those hospitalized, some subset of those patients also require intensive services. For each and every one of these cohorts, we can ask questions about what their baseline characteristics are, and as well as what are their follow-up treatments and outcomes. To expand this further, we stratified each and every one of these cohorts based on multiple characteristics, including demographics such as age and gender and race, and as well as important comorbidities such as hypertension, type 2 diabetes, and heart disease. So for each and every one of these cohorts, for each and every one of these subgroups, we can start to understand and fingerprint what does it look like in the real world experience of patients with this disease. And for each of those cohorts, we can look back from the time that they qualify for those populations to answer questions about pre-indexed characteristics of medical history, summarizing their demographics, their prior conditions, and their prior medication use. This can include features such as the symptoms of the disease and the onset of acute clinical events. But we can also look forward from that date to understand what was their medical experience at the time of entering these disease states, as well as what were their outcomes and treatments in the 30 days following. The CRIBDIS study was aimed at generating a large-scale characterization across all of these populations, but also running this across the entire Odyssey community with the goal of generating a large repository for the disease natural history. The results of this are currently being developed through a series of manuscripts, but all of the results are publicly available at this URL, data.odyssey.org/COVID-19 characterization CRIBDIS. And what I'll do briefly is show you those results. What I'm showing you here is the CRIBDIS website. On this interface, you can explore all of the different databases that have performed this analysis. In this drop down here to the left, you can see all of the databases listed. I've selected the HERA database, the CityApp electronic health record from Spain, and the IQVIA open claims database from the United States. For each database, we can then explore the various cohorts that we may be interested in. You can see I've selected a couple here. And then we can also select the specific stratification factors that we may be interested in. So in this table, you can see here, I've identified patients who are tested for SARS-CoV-2, who have at least 1 year of prior observation in the database. I've provided that overall and stratified by sex being male or female. And each of the databases are listed as a column to tell us the number of patients. So we can see in the HERA database that at the last time of running this, there were over 230,000 patients who were tested for SARS-CoV-2, as compared to 148,000 in the CityApp database and 740,000 in the IQVIA database. Of those, we can see how many patients were diagnosed with COVID-19 or tested positive. In the HERA database, that's 7,600 patients as compared to over 120,000 in CityApp and 460,000 in the IQVIA US database. And we can further subset those to patients who are hospitalized with a diagnosis and can examine those populations. Now, for each of those populations, we can go on to characterize the patients. Again, by selecting the database of interest, the cohort of interest in the population, we can look to examine patterns in the populations. Here I'm showing demographics and showing the age distribution. And here we can see important differences between databases. The population of those who were hospitalized with COVID-19 in the HERA database was much younger than what was observed for the hospitalized patients in the United States and in Spain. We also in this tool can actually compare cohorts to allow us to identify important differences. And the work of the Odyssey community right now is to examine these data and understand these differences so that we can provide insights to the broader clinical community. The next thing I'd like to highlight is the work of patient-level prediction. And here I'd like to reinforce the work of the COVER study that has produced a prediction that allows people to understand amongst those who are feeling COVID flu-like symptoms, what is their risk of being hospitalized, requiring intensive services, or dying. In this work, we developed a prediction model using patients with influenza, and we externally validated that model across multiple databases who had experience of patients with COVID. Here, this work, which is currently posted on medRxiv, describes the model development process and the results. What I'm showing you on the left-hand side is a schematic for a simple way to use this risk score. By answering simple questions about demographics and baseline medical history, one can produce a score that can be translated into a predicted risk for a given individual. This prediction work, in addition to producing a manuscript that is currently under review, we've also produced an interactive website that allows individuals to be able to generate their own risk based on their baseline characteristics. While this work is still awaiting publication, we've already seen it receive attention, including by the Health Ministry of Catalonia, who specifically identified the cover index as one of their indicators they're using to measure the impact of a given outbreak. The cover model, as described here, is available again on an interactive website at data.odyssey.org/COVID-19 cover prediction. And I'll highlight that briefly here. On this website, we can actually examine both the model itself as well as its performance around the world. To calculate your own risk, you can actually just put in your particular age, your gender, and identify what baseline characteristics you have. And this tool will actually calculate your risk of being hospitalized, your risk of being hospitalized and requiring intensive services, and your risk of death. Not only that, but this website also provides you a summary of exactly what models have been performed and what their performance was, giving us an understanding of how reliable this evidence is. So in summary, I think that observational data has a huge potential to positively impact our pandemic response. We're seeing clearly that governments, regulators, product manufacturers, and clinicians, they need to better understand COVID-19 to inform vaccine development and therapeutic evaluation, and ultimately the treatment and management of patients. Odyssey's data network provides the largest international collection of databases with real-world experience of patients with COVID-19, and it's tremendously useful to have collaborators such as HERA, as well as academic experts throughout South Korea being part of this global effort to learn as much as we can. Odyssey's data network allows evidence generation across a range of different use cases. Here I've described for you how it's important for us to characterize baseline characteristics of COVID patients and to understand current treatment patterns. We also can use these data to identify patients at highest risk of adverse outcomes, as I showed you in the cover model. And as Danny previously showed you, we can also use these data sets to enable estimates of the effectiveness and safety of therapeutic interventions. Now, in addition to generating reliable evidence that we hope informs important decisions, I think what we're also learning from this COVID pandemic is the opportunity of how real-world data can be used to responsibly support decision-making at various levels, including regulatory decision-making and governmental policy decision-making. And I think the HERA data set provides an excellent example of how a tremendous national resource can become an important and valuable public health resource, not only for Korea, but for around the world, as demonstrated by your leadership in participating in the Odyssey community. So with that, I'll stop. I want to thank you again for allowing me to participate in your session and look forward to a rich discussion.